On behalf of NNF Gujarat, I, Dr. Prashant Karya, Secretary, Gujarat NNF, welcome one and all to today's PG seminar, Bronchopulmonary Dysplasia. The seminar will be presented by Dr. Suhani Patel, and today we are having two experts, Dr. Pradeep GCM and Dr. Niraj Gupta. Along with that, we are having Dr. Dhiren Thakkar as the moderator. So Dhiren Thakkar is a neonatologist. He has done his fellowship in neonatology from Australia, and at present he is working at Urban NICU. So welcome, Dr. Dhiren.
Thank you, Prashant. Thanks for the warm welcome. Good afternoon, everyone. I believe I am audible to you all. Okay.
Yes.
So today we have an interesting seminar on bronchopulmonary dysplasia, and we have got our two experts with us. I would like to introduce them one by one. First, we have Dr. Niraj Gupta. He is a DM in neonatology and presently additional professor in the Department of Neonatology at AIIMS Jodhpur. He has a lot of academic achievements to his name, including more than 50 publications and Cochrane reviews. He has also guidelines, and he's involved in extramural research project as PI, and has done RC PCH visiting fellowship in 2019. Welcome, Dr. Niraj. And along with Dr. Niraj, we have with us Dr. Pradeep GCM today. Dr. Pradeep is also a DM in neonatology from PGI Chandigarh. He is working as professor and neonatologist as Ramaiah Medical College, Bangalore since 2006. His areas of interest in neonatology are neonatal ventilation and neonatal nursing training. I welcome Dr. Pradeep also to this seminar. As a presenter, we have today with us Dr. Suhani Patel. Dr. Suhani has done her undergraduate as well as postgraduate training in pediatrics from DY Patel Education Society, and currently she is pursuing her fellowship in neonatology at Urban Newborn Care Center in Ahmedabad. Welcome, Dr. Suhani. Without wasting much time, I would hand over things to Dr. Suhani to get started with the seminar. Over to you, Suhani.
Good afternoon, all. Today I am going to talk on bronchopulmonary dysplasia, which is the most common chronic lung disease of childhood. Recent advances have resulted in improved survival of extremely low birth weight infants, but not on the incidence of BPDs. So there is incidence of BPD is a higher these days. Northway in 1967 described BPD as a severe lung injury in relatively mature preterm infants who survived hyaline membrane disease with aggressive ventilatory support and high FiO2 exposure for prolonged period. These infants were born before antenatal steroids are introduced and postnatal surfactant exposure, and ventilator are just being used for the neonates. In newer BPD, infants affected are less than 26 weeks of gestational age, having initial milder course requiring low level of supplemental oxygen and ventilatory support. The definition of BPD are kept on changing according to evaluation for the infants. According to NIH, infants less than 32 weeks who received supplemental oxygen for first 28 days are labeled as BPD. But the chronicity of BPD is defined as 36 weeks of postmenstrual age as mild, moderate, and severe. In mild, there is no supplemental O2 requirement. In moderate, supplemental O2 requirement is less than 30%. And in severe, supplemental O2 requirement is more than 30% or CPAP or ventilatory support. For infant more than 32 weeks, BPD defined as supplemental O2 requirement for the first 28 days and severity is defined as 56 days of postmenstrual age. NICHD NICHD in 2018 has given a modified classification of BPD in less than 32 weeks of gestational age infants according to mode of respiratory support administered in 36 weeks of postmenstrual age. In grade 1, if the infant is on nasal CPAP, NIPPV or nasal cannula flow more than 3 liters per minute with room air, or the infant required high flow nasal cannula and hood by O2 by hood with 22 to 29% FiO2 and nasal cannula flow less than 1 liter per minute with 22 to 70% FiO2. In grade 2, if the infant required invasive positive pressure ventilation with 21% FiO2, nasal cannula NIPPV or nasal cannula more than 3 liters per minute with 22 to 29% FiO2, or nasal cannula flow less than 3 liters per minute with more than 30% FiO2, and nasal cannula flow less than 1 liter per minute with more than 70% FiO2. In grade 3, baby require invasive positive pressure ventilation with more than 21% FiO2, or nasal CPAP, NIPPV or nasal cannula more than 3 liters per minute with 30% more than 30% FiO2. In grade 3A, they have involved infants who are died between 14 days of postnatal age or and 36 weeks owing to persistent parenchymal lung disease, and there is no other attributable factors for respiratory failure. Infants with less than 28 weeks of gestation, the overall incidence of BPD is 33 to 50%, and according to NICHD study, the incidence of BPD is 22 to 28 week neonate is 40%. According to AIM studies, it is 33%. An infant with BPD, 44% develop chronic respiratory morbidity. First, we have to know the etiopathogenesis of BPD. Lungs developed in 5 stages: embryonic, pseudoglandular, canalicular, saccular, and alveolar. And respiratory system are divided into 2 zones: conducting zone and respiratory zone. Conducting zone is not required for the gas exchange. Infants who were born before 28 to 26 weeks of gestational age, their lungs are developed up to the canalicular stage, and some other saccules are there. Surfactant production starts from 25 to 26 weeks of gestational age, but the full surfactant action at 36 weeks of gestational age. Infants who were born before 28 to 26 weeks of gestational age, who were supposed to be in utero with their non-functional lungs, are exposed to the grass breathing. And our efforts to ventilate them causes injury to their underdeveloped lungs. In original BPD, there is area of hyperinflation, atelectasis, and fibrosis. But after antenatal steroid and surfactant therapy and lesser respiratory support, in newer BPD, we have seen diffuse haziness and hyperinflation. But in the histopathologically, there is alveolar hyperplasia. There is fewer and larger alveoli, which reduces the surface area for gas exchange. BPD is the causes of BPD, and prematurity is the most common cause for the bronchopulmonary dysplasia. Other etiological factors are IUGR, placental dysfunction, chorioamnionitis, preeclampsia, maternal smoking, and genetic predisposition. Postnatally, mechanical ventilation, O2 toxicity, sepsis, PDA, and nutritional deficiency. These all are causes lung injury, and there is increase in inflammatory cytokines, which causes injury to the airways, vascular injury, and interstitial damage. And there is respiratory failure and pulmonary hypertension, which causes early respiratory death. If there is repair and regeneration, they may develop bronchopulmonary dysplasia, or repair and regeneration occur. There may be a disease resolution. Supportive measures. BPD itself is a clinical diagnosis, but there are supportive measures to define BPD. Infant present with intermittent cyanotic or life-threatening episodes like BPD spells. Physical examination shows tachycardia, retractions, swells on auscultation. Chest X-ray shows diffuse haziness, normal to low lung volume, and cardiac evaluation shows there is no other pulmonary causes of respiratory failure. Prevention of BPD must start from the perinatal period or in delivery room or in NICU. Antenatally, use of antenatal corticosteroid in the mother who are expecting preterm deliveries reduces the chances of respiratory distress syndrome and mortality. Use of prenatal antibiotic in case of maternal chorioamnionitis and management of maternal health treatment of PIH and smoking cessation reduces the IUGR birth. Management practices in the delivery room. After delivery, during first golden hour, our main goal is to establish functional residual capacity, improving the pulmonary blood flow and adequate tissue oxygenation. But the major crux is to achieve this with minimum lung injury. BPDs result when the structurally and functionally immature lung is subjected to large volume breath, time of bagging, ventilator-induced injury, and high oxygen level. The following practices at the time of birth would help to prevent the BPD. If possible, delayed cord clamping, use of blended oxygen, use of pulse oximetry to guide the need for oxygen, use of delivery room CPAP reduces the chances of BPD by 11%, and use of gentle positive pressure ventilation for apneic and bradycardic needs. Preventive measures in NICU. Some meta-analysis shows that when intubation is compared with non-invasive respiration, there is chances of less BPD in non-invasive ventilation. So the primary use of nasal CPAP is used, and NIPPV is used after extubation to reduce the post-extubation failure. Surfactant administration. The use of surfactant early within the first 2 hours of life to neonate needing more than 30% FiO2 reduces the risk of BPD. In Tolstoy trial, late surfactant dosing in ventilated preterm infants did not improve the survival without BPD. The use of less invasive surfactant administration has shown to decrease the mortality and BPD by 30% at 36 weeks post-menstrual age. LISA is always better than Ensure, and Ensure is better than mechanical ventilation. Lung protective ventilatory strategy. Ventilation practices should aim at preventing volume trauma, barotrauma, atelectrauma, biotrauma, rheotrauma, and oxygen toxicity. Use of volume targeted synchronized mode of ventilation. Target tidal volume 3 to 5 ml per kg. PEEP is 5 to 7 centimeter of water to decrease the chances of atelectasis. Permissive hypercapnia. Target PCO2 45 to 55 millimeter of mercury and maintain SpO2 90 to 95%, and early extubation in the infants who do not require end expiratory pressure and FiO2 requirement is less than 30%. Caffeine citrate. Caffeine works by stimulating the respiratory center, also reduces the fatigability of diaphragm, reduces the need for additional respiratory support. Use of caffeine during first 10 days after birth shows the reduce in the risk of BPD by 47 to 36%, and it improves the survival without neurodevelopmental disability. Recent studies suggest that beginning caffeine therapy within 72 hours with higher loading dose, higher loading and maintenance dose result in the greater reduction in the BPD risk. Use of vitamin A. Vitamin A is important for the maturation of epithelial cell lining of respiratory tract, and it requires for the alveolarization. 5,000 international unit IM thrice a week for 1 month in extremely low birth weight infant has shown to reduce BPD by 10%. Some ongoing randomized control trial investigating the enteral vitamin A may help to reduce the incidence of BPD or not. Nosocomial infection prevention. Implementing infection control policies in the neonatal NICU also reduces the risk of BPD. Human milk is the most underrated strategy to prevent the bronchopulmonary dysplasia. Recent observational studies shows that mother's own milk reduces the risk of BPD. and consider the treatment of hemodynamically significant PTA in infants who have respiratory decompression or cannot be weaned from mechanical ventilation. Postnatal steroids. The current evidence based from Cochrane systemic review does not recommend use of dexamethasone less than 7 days of birth in ventilated neonate. It has shown reduction of BPD, but it is associated with major complications like GI perforation, cerebral palsy, and major neurosensory disability. Hydrocortisone, early prophylactic low-dose hydrocortisone started in the first week in selected ventilated neonates has shown improvement in survival rates without BPD. The largest of these is the Prerequisites trial. In late surfactant therapy, dexamethasone is used after 7 days of life, shown an obvious benefit in the reducing the incidence of BPD. It promotes early extubation and neurodevelopmental side effects are there, but lesser as compared to use early. The reviews concluded that the benefit of postnatal steroids may not outweigh the potential harm. Thus, it is prudent to use steroids only as late strategy in selected extremely low birth weight infants who are difficult to wean. NICHD has advised an online outcome estimator like BPD calculator to identify the neonate who are at high risk for BPD and who may benefit from the postnatal steroid. But these calculators are not used for the Indian ethnicity. Those should be minimum and should be used for minimum duration of time. To maximize the benefit and minimize the side effect, use dexamethasone around 14 to 21 days. If neonate is successfully extubated, then continue the dose till the 9 days. And if one is not able to achieve extubation, since 3 days after steroid therapy, then steroid should immediately stop. Recent Cochrane meta-analysis does not recommend early or late inhaled corticosteroid use for prevention of BPD. And Neurosys trials shown the decreased BPD rates among survivors were at the expenses of greater mortality. Combining surfactant with budesonide in a recent study has shown a significantly lower rate of BPD without any significant side effects. Fluid and nutrition. Data indicates fluid restriction in preterm infants reduces the incidence of BPD by preventing excess pulmonary fluid, thereby improving the air-gas exchange. In cohort study from NICHD, infants who either died or developed BPD had a higher fluid intake and a lower weight loss during the first 10 days of life compared with those who survived without BPD. So initially provide fluid intake adequate to maintain urine output 1 ml per kg per day and serum sodium concentration 140 to 150 milliequivalent per liter. Early aggressive parenteral nutrition with an early transition to enteral feeding may help decrease the incidence of BPD. Postnatal nutritional deficit is an independent predictor of bronchopulmonary dysplasia. Treatment of established BPD. Lung problems in BPD are there is decreased functional residual capacity, there is decreased lung volume and decreased lung compliance, and impaired gas exchange and increased airway resistance. Ventilator setting strategy in the established case of BPD. Volume targeted synchronized mode is preferred. Inspiratory time is longer, would help in uniform lung inflation. PEEP 7 to 8 millimeter of mercury to maintain the functional residual capacity, and it also prevent the atelectasis. Lower rate prolongs the expiratory time and thus prevent the air trapping. And tidal volume 6 to 8 ml per kg to support the neonate with high resistance and variable lung compliance. And target pH more than 7.2, PCO2 55 to 60 millimeter of mercury, and SpO2 90 to 95% in preterm neonates. Once they become term and their retina become mature, SpO2 target is 90 to 98% to prevent the pulmonary arterial hypertension. Diuretics have not been shown to improve the incidence of BPD. They can, however, be used sparingly if there are clinical radiological features of pulmonary edema. Bronchodilators, infants with bronchopulmonary with BPD spells or chronically increased resistance may be benefit with the bronchodilators like albuterol or ipratropium bromide, and medication for pain control and sedation are also used. infant with BPD, they have higher metabolic rate and higher energy expenditures. They require more calorie intake, 150 kilocalorie per kg, and protein 3.5 to 4 gram per kg per day for their lung repair and growth. All efforts are made to provide mother's own milk. If mother's own milk is not available, human donor milk is given. Provide vitamin, trace elements, and other dietary supplementation. Maintain hematocrit approximately 30% to 35% and hemoglobin 8 to 10 gram per deciliter. And steroids, there is no clear indication for the use of systemic steroid in established BPD. In clinical practice, a short course of oral steroid is often used during bronchopulmonary BPD to wean off supplemental oxygen. Associated complications. The pulmonary hypertension is a major complication which causes morbidity, which increases the morbidity, duration of hospitalization, and mortality. It affects 16 to 25% of infants with BPD, and 2 years mortality rate is 38 to 43%. Chronic hypoxemia causes hypoxic vasoconstriction and pulmonary hypertension. The Pediatric Pulmonary Hypertension Network recommends that echocardiogram should be performed to screen pulmonary hypertension at 36 weeks post-menstrual age, and in more severely affected infants, we may begin monitoring at 32 weeks of post-menstrual age. Management of pulmonary hypertension includes maintenance SpO2 between 92 to 95%. Sildenafil and inhaled nitric oxide is useful in the setting of acute pulmonary hypertension. Other complications are upper airway obstruction, systemic hypertension, infection, central nervous system dysfunction with extrapyramidal signs, sensory neural hearing loss, ROP, and early growth failure. Some babies who are just need low flow oxygen even after reaching the term, and they showing the regular growth, for these neonate parents can be given an option of home oxygen therapy to cut the cost of NICU stay. Important prerequisites are infant maintain SpO2 more than 80% if kept in the room air for 30 minutes. Hemodynamically stable. Parents should be confident with oxygen delivery unit. A small handy pulse oximeter should be sent. They should be familiar with basic resuscitation technique. In addition to standard immunization, infants with BPD should receive pneumococcal influenza vaccine and palivizumab. If possible, the family members also should receive this vaccination. Outcome, BPD is the mortality in BPD is 10 to 20% at the 1 year of age. Respiratory outcome, they are more prone for bronchiolitis and pneumonia. Pre-hospitalization chances are twice as compared to normal babies, and there is reduced exercise capacity. In neurodevelopmental outcome, there are cerebral palsy, neurosensory impairment, deafness, blindness, cognitive and educational and behavioral problems, and growth failure. Investigational therapies without proven efficacy. Inhaled nitric oxide, recombinant human coppers in superoxide dismutase. It is given every 48 hours to intubated neonates, there are trials showing reduced in the chances of bronchiolitis and pneumonia at the 1 year of age. Insulin-like growth factors are important for the lung growth. Recombinant human club cell protein 10 and mesenchymal stem cells, they are anti-inflammatory and azithromycin. But larger trials are required to implement or proven efficacy of these drugs. I'm ending this seminar with showing this baby who is preterm 28 plus 3 weeks, delivered by lower cesarean section for leaking more than 5 days, 1.2 kg, kept on conventional ventilation for hyaline membrane disease, PDA ligation on 29th day of life, and fundoplication done on 68th day of life, and extubated and put on CPAP on 75th day of life. Dart therapy given in view of BPD. Baby was requiring side oxygen, and thereafter baby has several episodes of BPD spells and apneic episodes, and the oxygen is continued till baby discharge at home, and on follow-up oxygen tapered and stopped. He has behind his development in some aspect, but he is alive and now surviving without O2 supplementation. Some take-home messages from this seminar is steps to prevent BPD must start from perinatal period, use of nasal CPAP as primary respiratory support, avoiding intubation whenever possible, administration of surfactant via LISA, or ensure use of volume targeted ventilation, preferable use of NIPPV, early initiation of caffeine, use of vitamin A, use of dexamethasone in selected neonates who require ventilation for more than 2 weeks, and maintain growth for all neonates with BPD.
Thank you, Dr. Suwani, for very good and elaborate presentation on BPD. And I must say that the last slide describes everything that you actually have wanted to tell the audience. So the take-home messages are really very important for everyone to understand that how we can prevent the BPD and how we should
And your
manage the
voice
patients
is
with
very
BPD.
low.
Uh,
Your voice is very low.
okay, is it better now? Hello.
You can use without headphones. It's very low.
Okay, sure.
प्रशांत वो सॉफ्ट स्पोकन है इसलिए वो लो
Is it
रहता है.
No, no.
so is it better now?
Slightly better. Yeah.
Yeah, so now first I would like comments from two of our experts in brief regarding the seminar topic today on BPD, and then we'll take the questions from the audience one by one. So I invite Dr. Pradeep to give a brief overview about BPD.
Yes, thank you, and congrats, Dr. Sohani, for a very crisp and a beautiful presentation on BPD. I think you did cover most aspects of it. Now, there are three important comments that I want to make. Talking about babies about 20, 8 weeks and above. So the incidence of BPD might be much less, but off late, I think most of us have started to cater 26 weekers and 27 weekers. So our incidence of BPD will go up. So we don't have BPD, it's only mean we are probably catering to a bigger group of babies. The second important aspect about BPD in terms of prevention, because when the BPD sets in, I think you are already, you lost the game, and whatever you do, eventually it is just wait and watch and trying to give some kind of a supportive treatment. So all your efforts should be more towards how do I prevent BPD as such. I always summarize it as 3 A's, antenatal steroids, avoid intubation and avoid infection, and adequate nutrition. I think we need to go back and add and say that it has to hit this, saying that we have to get all our preterm mothers for antenatal steroids. We need to avoid intubation. We need to avoid infections, maintain a good oxygen target saturation, which you need to educate your nurses. They are the frontline workers. And most important aspects, which most of time sort of gets not so important, is nutrition. In prevention, even when you have established BPD, my take is get their nutrition very good, get them to grow well. Most of your BPDs want to come out. I think that's very, very important in terms of the third important aspect, which you did put on a last slide, is I have had a very bad experiences with pulmonary hypertension associated BPD, which again is sort of a neglected the aspect of BPD. You need to understand any baby who has a BPD needs to get a routine screening echo, monitor for features of pulmonary hypertension. It could be mild, it could be moderate, severe, depending on what BPD it is. Because as one area, again, I see that many people do not pay attention to monitoring for pulmonary hypertension in cases of BPD. I think that are the three important aspects that I wanted to, probably my comment on the BPD side.
Yeah, thank you very much, Dr. Pradeep. Of course, that the 3 A's that you mentioned would definitely everyone would be, looking at or trying to achieve when they are caring for extremely preterm babies in order to avoid the BPD or maybe treat it. Now I would invite comments from Dr. Niraj Gupta before we take questions from the audience. Dr. Niraj, you will have to unmute yourself.
You can unmute.
Niraj, you are muted yourself.
Yeah.
Can you unmute me?
Yeah, you unmute.
Yeah, you are unmuted.
Okay, thank you. That's all. So thank you, Sohani. I think it's a complex topic and you have tried to present and summarize in a very nice way. Now, if we see BPD as a disease, it reflects two broad aspects. One is that the occurrence of BPD reflects our practices. Whether we talk of our antenatal practices, whether we talk of our perinatal practices, or the postnatal care or the postnatal practices. What it means, the incidence of BPD in any unit reflects the practices, the quality of those practices in that unit. And as rightly pointed out by Dr. Pradeep as well as Sohani, that if we have to decrease the incidence of BPD, we need to focus in all these aspects. BPD and the unit which has high BPD invariably will find the other morbidities, whether you talk of retinopathy of prematurity, whether you talk of NUCs, whether you talk of sepsis, will also be high. Because ultimately the risk factors are same. So which means most of us, means everyone, all of us knows what needs to be done, but the reality is that when it comes to the implementation, somehow we fail there. Maybe the team approach we try, but then the frontline workers are not available, or they are not sticking to those protocols despite of their best efforts. So we need to find out that in each context, in each of our unit, what are the problems? Like there may be 10 problems, which is contributing more, which is contributing less, and that's why BPD is one disease where if you focus only on one strategy, you will not be able to decrease. You need to hit hard on this entire care bundle package. It's a bundle care. That is one aspect. The second reflection of BPD is in terms of long-term outcome. A newborn or an infant who has developed BPD, his long-term neurodevelopmental outcome is going to be bad. So if my resident tells me, sir, this is a patient, he's coming in follow-up today and he has BPD, it means my hairs, my ears are raised that yes, there are high chances of neurological issues apart from the pulmonary comorbidities in these babies. And a very beautiful paper by Dr. Barbara, where she said, use the formula 1, 2, 3, where she said that BPD, the ROP, and the CNS findings in terms of IVH or PVA. If a newborn has one disease, in that population, the outcome was, I think, around the neurodevelopmental disability at 18 months, somewhere we're touching around 30 to 35%. If you have two comorbidities, it went by another 5 to 10%. And if you have all the three, then it further aggravated. So BPD is a disease which is reflecting on both the sides, and we need to hit hard on all the aspects to improve our outcomes. And if we are able to decrease BPD, you will find that so many other morbidities will automatically decrease in that unit. So it goes hand in hand with all the kind of things. So I think that's all from my side, because Sohani has very well covered, and Pradeep sir has already given stress on those 3 A's plus all those kind of preventive strategies. Thank you.
So, as Dr. Niraj rightly pointed out, that BPD has a multifactorial etiological background, and the strategies have to target not only the respiratory management, but also the important aspects of the neonatal care, including the nutrition and avoidance and prevention of the neonatal sepsis. Maybe we can start taking questions from the chat box, and then down the line, again, we can invite comments from the experts as well as the other audiences. So we'll direct the questions first to the presenter, like Dr. Sohani, and then if required, Dr. Pradeep and Dr. Niraj can give their inputs. So Dr. Ronak has asked that, is there any difference in the incidence of BPD with different types of surfactants that we use currently, or those are available in the market? Suhani, you will have to unmute yourself.
Some studies have shown that protein-derived surfactant reduces the chances of BPD And there are also prophylactic surfactant therapy and prophylactic surfactant therapy and rescue surfactant therapy, for which the rescue surfactant therapy is most important, because in prophylactic surfactant therapy, we are giving surfactant to the infants who did not have respiratory distress syndrome. Rescue surfactant therapy, protein derived surfactant, is important for reduces the chances of BPD.
We all know that surfactant replacement therapy itself is a long topic, and we have already had a full seminar on that. So we won't go into much of the details, but my question to Dr. Pradeep would be that pertaining to this particular questions asked by Dr. Ronak, would you like to add anything what Suhani has said already?
I think the question that he has asked is between the different types of surfactant. All we know is between the synthetic and natural, natural has been shown definitely much superior. But between the natural surfactant, I don't think any of the surfactant have shown superiority in terms of prevention of BPD, not to the best of my knowledge. So that was his question specifically.
Okay, perfect. Next question is by Dr. Deepak. He's asking that what is the disadvantage if you use volume control ventilation? I mean, Dr. Suhani has clearly, stated in the seminar for the strategies to prevent or avoid BPD, that we should actually be using a volume control ventilator or volume targeted ventilation rather as much as possible. But Dr. Deepak wants to ask that is there a particular disadvantage when you use volume control ventilation? Dr. Suhani?
In volume control ventilation, the more expertise is required, and we are giving tidal volume for this neonate is very small, so there is a chances of less tidal volume is provided to the baby, which because of the dead space and around the peritubular leak. If there is peritubular leak, the tidal volume is provided is less.
Okay. Dr. Niraj, would you like to add anything to what Suhani has said, that what is the disadvantage if you use volume control ventilation?
Okay. So before I come to the question per se, let us try to understand this word volume and control. The reason is that if you see previously, the typical ventilation used to be the pressure limited or pressure controlled ventilation. Then there were experiments on the rabbits which showed clearly that the much more dangerous is the volume trauma, not the volume trauma. So the people wanted to shift to the volume ventilation, volume controlled ventilation, but unfortunately the kind of processors which we are using, the circuits in the ventilators, still they are not that much specific that we can depend if you have to deliver 0.5 ml of tidal volumes, those kind of things. So most of the ventilators which we are using right now, they have hybrid mode where we are primarily using the pressure limited ventilation, and on top of that there is a knob which you call as TTV in SLEs or volume guarantee in your Drager baby law. That means there is no conflict of interest with any company, but just to the different terminologies which are being used in these ventilators. So there we are using hybrid mode. So there is a baseline is a pressure limited ventilation, and on top of that you are putting a volume guarantee, so that once at even lower pressure the volume is achieved, we are not crossing, we are not going to the higher pressure which have been set. The typical volume controlled ventilation is actually being used in very few units. One of the units is in Middlesbrough in UK, where maximum are Indians and they are quite comfortable in using volume control. That's the primary mode there. But I think most of us in India and in many places, we are using the volume targeted ventilation. I will not say volume control, it is a volume targeted ventilation. And for all practical purpose, volume targeted ventilation is better than your typical pressure limited ventilation. You talk of any kind of advantages, so it is better. So I don't see any kind of disadvantage with volume control ventilation, provided you have that ventilator which can deliver volume control and you have that kind of expertise. I don't have, because I have been trained and we have been using it volume guarantee, but I don't see any kind of reason or other volume guarantee or volume targeted ventilations are better than your conventional pressure controlled alone ventilations.
Thank you for that elaborate answer. Yes, Dr. Pradeep, you want to add anything?
No, I think what the participant wanted to know is probably limitations of using volume targeted or volume guarantee ventilation. I think what we need to understand is by physiology, volume guaranteed or whatever volume targeted is perfectly fine. I think what he wanted to know is why are we not using them? Why are we not, many units are not opted it? I think there are only limitations. One of the limitations is getting the right kind of volume guarantee or volume targeted ventilation, which should measure the expiratory tidal volume, not the inspiratory, which will hold defeat because that doesn't take into account the leak that happens. The second disadvantage is you need to have your flow sensors working 24/7. I think all of us have seen it, our unit, when you go into the unit, the flow sensors are not working, all your volume target guarantee goes for a 6. So I think it's just that getting the right kind of ventilator, right kind of a training is very, very important. And most important to understand that if you have your machine, please understand this machine should have one, measure the expiratory tidal volume. They should have compensatory mechanisms because if the patient coughs, I mean the baby coughs or if there's sudden changes, there should be a safety to protect the baby from going into a high tidal volume. And the third thing is you need to have your flow sensors intact, working 24/7. These are the limitations. I'm not saying these are disadvantages. These are the things that you need to keep in mind before you start jumping on to using volume targeted or volume guaranteed ventilation. Those are, I mean, you can put it as a limitation rather than disadvantage.
Basically, we can say that there could not be any disadvantage practically if we maintain all the necessary things required for achieving a good volume targeted ventilation, as Dr. Pradeep mentioned. Moving on to the next question, Suhani, if you want to take this, why vitamin A only for ELBW babies and not in LBW babies?
Vitamin A stores in liver in third trimester. So these extremely low birth weight babies are deficient of vitamin A, and after delivery we are not able to provide enteral nutrition for these babies. So mother milk also contain vitamin A, so we cannot provide vitamin A by enteral nutrition also. And we are giving trace elements in which the vitamin A is mostly degraded because of the light. So extremely low birth weight infants are more susceptible for vitamin A deficiency, and vitamin A is important for alveolarization. So we have to give vitamin A in extremely low birth weight.
Okay. Anything that you want to add, Dr. Pradeep?
I think his question was why not ELBW and VLBW? What was the question?
No, it says that why only ELBWs and not LBWs, but maybe we can understand that why only ELBWs and not LBW as well as VLBW.
As the answers are very simple. One is these are the vulnerable groups. So we are probably looking at the prevention of BPD, and the studies were basically done in 23 to 28 or less than 1 kg, and the recommendation is for that. Nobody stops it for giving the vitamin A for bigger babies, but in terms of BPD, it is we are targeting the high-risk population, which is the ELBW, and yes, with the recommended dose and regimen, and very well understanding they are born probably with less vitamin A, and we are looking at giving vitamin A to make sure the alveolarization is completed and reduce the incidence of BPD.
Thank you, Dr. Pradeep. Dr. Kedar wants to know about volume ventilation. Maybe we have covered most of it. He also wants to know that at ET level, I mean the Y sensor, or as per the ventilator display without Y sensor, how actually the tidal volume is measured. I believe that this is beyond the scope of this discussion because this goes more into the ventilation strategies. But yes, volume ventilation has very well been discussed by both the experts. So we'll move on to the next one. Dr. Ronak wants to know role of vitamin A in prevention. I mean, how vitamin A helps in prevention of the BPD. Dr. Suhani has already mentioned. Maybe you would want to answer this in brief. It helps in alveolization, you already mentioned. So any other role of vitamin A apart from that?
They are asking a role of oral vitamin A in prevention.
Yes.
So as the intramuscular injections are not available in India, there are some meta-analysis. Which are trying to prove the role of vitamin A. In this meta-analysis, they have given 10,000 international unit of vitamin A syrup alternate day for 28 days, and they have shown reduces the incidence of BPD by oral parenteral route also.
Dr. Niraj, any experience, or maybe Dr. Pradeep, you can also answer this. Any experience any one of you have with the use of vitamin A being given orally?
No, I don't have much experience with that, but all I know is giving intramuscular 5,000 international units, IM 3 times a week for 4 weeks is practically not, feasible for a 600, 700 grammars because of their poor muscle mass and vitamin injection being very thick. And, it's not very easy. You need a very wide bore needle to give it. So many times when I've discussed with people coming from Western unit also, I do not think it's a standard practice to give intramuscular vitamin A to most of these high risk, because the benefit that you're giving versus imagining 12 intramuscular injection of that thick vitamin A is practically not possible. But I haven't had much experience with oral vitamin A. I haven't tried. So,
Dr. Niraj?
So I have also not used vitamin A, and I think one of the major reasons for that why this strategy has not been used, despite of, I think we have almost every 2 decades, but the problem is that if you see the confidence intervals, the upper CI or the confidence interval is almost touching like 0.97, 0.98, which means it is very close to the line of equality. That is one thing. And second is, which Dr. Pradeep is highlighting, that in such a tiny creature, giving IM injections, the muscle mass is hardly anything there, and you are poking and giving IM injection, and that to 12 thing. So that's why most of the units are not practicing this. Second is that regarding oral, which Dr. Sohani was trying to highlight, I think we need more evidence in this direction. Yes, oral vitamin A can become the standard of care. There are a lot of issues with that. So, but yes, we don't know if the IM part is having that kind of effect size. So whether oral will be better, I don't foresee. So I think we need more research in this direction as far as oral is concerned, because for IM, yes, there is a clear-cut evidence, but because of that negligible effect, people are not using it.
And maybe with IM, the availability of IM vitamin A is also a big concern. I don't think it's available anywhere in Western India, as far as I'm aware. I don't know about the rest of the India. Is it available in South? Anyone?
No, nobody's using it, so I don't think they're even trying to market it.
Yeah. Okay.
Even in West, people have stopped. I don't think anybody's doing it as a routine. That's basically what I know.
Okay, the next question is on the postnatal corticosteroids. One doctor on YouTube is asking that what is the exact dose of steroids used in DART and how many days? So, Suhani, do you want to answer this?
That therapy is given for 10 days, 0.15 mg per kg per day for first 3 days, then 0.1 mg per kg per day for next 3 days, then 0.05 mg per kg per day for 2 days, and then 0.02 mg per kg per day for next 2 days.
It's a very standard treatment. Or I believe that everyone in the world possibly follows the same regime as far as giving the postnatal DEXA. And everyone should keep in mind that this is in regards to the use of dexamethasone as the postnatal steroid. Along with the use of the postnatal steroid, one question to Dr. Pradeep, that any experience with any other alternative postnatal steroid like prednisolone? At times there have been few studies that oral prednisolone as like for the prevention of BPD. Any experience or idea about it?
So I know about people who have tried oral prednisolone at a dose of 1 to 2 mg per kg per day, but I'm not too sure whether the evidence is too strong enough to say it should be routinely used. See, the whole the concept, only 2 things have been sort of proven beyond that. One is that Primlock, where people have tried low dose hydrocortisone in the first week and trying to say it does reduce, and the DART, which has shown not the endpoint. The endpoint did not make any difference. It was only that it helped your babies to come out of the ventilator. So anything else you use, physiologically it should all work. Whether I use hydrocortisone, whether I use oral prednisolone, the endpoint should be the same. But if you go by evidence, I think it is still a bit of a chaos, and talking about steroids and Bpd, there is still big question mark on what exactly are we looking at. Prevention, treatment, how long to give, what. Only thing we know is DART is safe because you have a cumulative dose of 0.89 mg per kg, and it has definitely shown to get your babies off the ventilator, not shown to reduce the incidence of Bpd though. So I do not know much about prednisolone. I know people have tried, but I don't think the evidence says, oh, you stop DART and use prednisolone, it has the same. To me, it should make some difference, but the endpoint of Bpd, I don't think any steroids have so far shown. And knowing very well the oral steroids, you have your issues by giving oral steroids. You are bound to get your babies onto the GI bleed and feed intolerance or gastritis. So I don't think I personally have ever used oral prednisolone. I have used inhaled, budesonide whenever I have had Bpd. That I think it's still the early evidence is still in favor of using inhaled steroids rather than oral prednisolone. My only take on oral prednisolone, I think you are going to damage the gut much more when you give oral prednisolone rather than giving that. But evidence-wise, I don't think that anything has shown to reduce the incidence of Bpd.
So, Dr. Niraj, Dr. Pradeep did mention about the use of hydrocortisone in early days, and he mentioned about the Premiloc trial. Can you throw some light on that?
See, actually, if you see that the oral steroids and the Bpd, I think there are so many trials have happened, and early versus late, and then among the early this Premiloc where people have used low dose hydrocortisone. But at the end of the day, the biggest challenge is that we want the maximum benefits with the lowest side effects. Now, when you're talking of a baby who is 28, 27 weeker and the brain is growing, and at that time, the rapidity with which the brain is growing in the third trimester, or means after birth, in that first 12 weeks or 16 weeks, you have a lot of neurons getting formed, the interconnections and all this kind of stuff which is having. Whatever steroid you give, it is going to have a negative impact on the brain. But and same happens when you're talking of the postnatal steroids. The question here is that the damage to the brain, which is happening because of the baby being stuck up on the ventilator and having a lot of comorbidities on it because of sepsis, because of issues with the nutrition, the damage which is causing because of these things versus the damage which you are causing to the brain by giving steroids. Out of these two damage, which overpowers and which gives you a net beneficial effect. So we as a whole, I can tell you that we use only DART regime. We have never used Premiloc as mentioned in the low dose hydrocort early thing. We have never used it because of these apprehensions. And we always try DART regime only in selected cases where by the end of third week or second to third week, we are stuck upon invasive ventilation and we feel that we will not be able to extubate this child. So the steroids are also causing harm to the brain. The prolonged ventilation and the associated comorbidities with it is going to cause the brain. You need to see that in your unit, the kind of outcomes which you have, the kind of practices, whether this therapy is going to be causing net beneficial effect on it. But as far as low dose hydrocort is concerned, we have never used.
Okay. Next, we have a question from Dr. Ronak asking that is there any difference in the incidence of Bpd when you use NIV or when you use CPAP? I mean, difference in Bpd between NIV and CPAP. Dr. Pradeep?
I think there was one trial which said that NIMV with surfactant, with mist, probably had a little advantage over CPAP and mist. I can't recollect that study right now, but I think there was some evidence to say that NIMV with mist probably works slightly better in terms of reducing the lung injury. I do not know whether the endpoint was Bpd, but I know that there was a study like that. Maybe I'll have to go back to that, but NIMV with mist. I'm not too sure just the CPAP and NIV, but I know about CPAP with mist and NIV with mist, but NIV with mist did a little better job protecting the lung and whether it ended up with reducing BPD, I'm allowed to check. Okay, then I said,
Dr. Hetal also wants to know that is there a difference between nasal CPAP and HFNC as far as prevention of BPD is concerned?
no, I don't think there is any trial which has shown that HFNC is better or CPAP is better in terms of BPD. All we know is as a primary mode, all we know about HFNC is HFNC as a primary support for respiratory distress syndrome has not been proven to be as good as CPAP. In terms of post-extubation, both HFNC and CPAP have been equally good. HFNC scores over CPAP only in terms of the comfort to the baby and scores better by the nurses and parents. Other than that, I don't think there is any evidence to say HFNC does any good over CPAP.
Okay. We have a question from Dr. Urvi. Maybe we can't go into much of the details about this, but just to add it to the list, what to counsel for outcome of a 26-weeker with a corrected gestational age of 32 weeks now with grade 2 IVH and BPD? I guess anyone wants to just take it in brief. I am sure that this can't be answered in brief. Dr. Niraj, would you want to say anything?
So when you counsel, you need to, I'm just talking about broad principles. You can,
Yeah, so maybe we can take this question in the light of counseling, like in terms of like maybe introduction of steroids or maybe what we call an evolving BPD situation. How do we deal with it?
okay. So I think here, when you counsel for any kind of thing, you need to have data of your unit, because then you say that, okay, in my unit, this is this, what is happening, and based on that, I'm counseling. So here you have a situation, you are sitting at 6 weeks post-menstrual age of a 28-weeker, you said 26-weeker baby.
Yeah, 26.
Post-menstrual age, and then baby is stuck up on ventilation and had grade 2 IVH, I don't know, unilateral or bilateral. So one aspect is that the parents would like to see that, okay, how early the baby can come out of the ventilator. So again, it depends on the kind of settings, and by this time, I'm sure that if the baby would have been on invasive, you would have already discussed about the DART regimen, you would have impinged, gone for that. Plus, of course, as we have multiple times highlighted, that it is not only this part you need to focus as a whole in terms of nutrition, which is very important, because if you don't give nutrition, the lungs are not going to grow, and other therapies. So that is one aspect you need to tell the parents that yes, this is what we are anticipating in this, and this much time it will take. And second is, of course, the IVH part, which I feel that because most of the IVH happens in first 4 days, 5 days, 7 days. So you must have dealt this component much earlier, telling that yes, this is going to have the effect on the outcomes. But against the total holistic outcome, I think, will depend at the end of the day what all things have happened in this. It's not a very straightforward kind of situation. So when the situation is there, you accordingly counsel the parents and tell them with your own unit data.
I think only point we need to add here would be the parents at this stage. We are looking at a very long-term, issues. The BPDs is not going to get out in next 1 week and go out. I think what you need to add to your counseling is definitely the long stay, the financial implications, the social implications of a long stay in NICU, and even the baby being stuck on the oxygen, maybe going back home on home oxygen. I think this is a time when you need to start assessing the parents, trying to look at their background and see how well you can plan your, the subsequent care, whether it is giving postnatal steroids, giving home-based oxygen, a lot of things at this stage. I think this is a time when you are really having a one-on-one discussion with the parents, giving them a very realistic picture about what is expected, in terms of the stay and in terms of what is expected in terms of the outcome. So we need to be very honest and giving them a clear picture, because at this time, a lot of issues are with the finances. I think it's very, very important in India to talk about finances at this stage, knowing very well the baby is going to get stuck for a long time. So that's an added point into the counseling. Yes.
I would agree with both Dr. Niraj and Dr. Pradeep that this is a situation that the practicing neonatologist would possibly come across day in and day out when they are taking care of the Elbws. That counseling of parents at the same time making, the clinical decisions, because introduction of steroids is not only a big decision for the neonatologist, but also, agreeing onto it is going to be equally difficult for the parents. And at the same time, as Dr. Pradeep rightly said, that options like home oxygen, and the alternatives must also be discussed, so that an overall outcome can be offered as much better as possible.
Just to add one thing, that
Yes.
when you impinge on postnatal steroids, that is DART regimen or any other regimen if you are using, please take a written informed consent. That's very important.
Yes, this is really very important, that written consent.
It is very important, very important. Without that, one should never impinge on this kind of thing.
Because I mean, I'm sure that many of us are clinicians, specifically, so much busy into doing the other things, that we at times are really very poor at documenting things, or maybe making ourselves secure or safe when it comes to the medical legal litigations. So really very good and important point highlighted by Dr. Niraj. I guess now we have maybe only a couple of minutes left. So last questions maybe a question maybe somebody is asking, Dr. Anand Joshi is asking, that does intratracheal steroids with surfactant have any role in reducing BPD? Suhani, you want to answer this?
There are many studies who shows intratracheal steroids when combined with the surfactant therapy, it reduces the chances of BPD. As budesonide or any steroids, when we introduce, it also decreases the inflammation. It acts as an inflammatory agent.
So any comments from the experts on this using?
I think the evidence is there, but I think it's too early. These are only smaller trials that did show. Basically, you need to understand the logic. When you're just giving inhaled budesonide, what they say is it does not reach the alveoli. So you are using surfactant as a carrier to take budesonide and sit in the alveoli. And it does have, I mean, it has shown a reduction in the BPD, but I think the only thing is too early and it's too small a study to make it as a standard of care. So at this point, I think it is promising, but not well proven beyond doubt in terms of statistics and evidence.
So I completely agree with Dr. Pradeep. I would also like to highlight here another point. Whenever we talk of any intervention, unfortunately, with the upcoming of evidence-based medicine, which has all goods, the basic philosophy which we have forgotten is that if you start giving a XYZ drug to everyone, in some it is going to cause benefit, in some it is going to cause harm. Something which has happened with the steroids in BPD, that you start giving to everyone, it is going to be harmful. So people started narrowing down that which is that population where the benefits will be maximum and the risks will be minimum. So similarly here, I personally feel that we need to identify that subset, which is probably difficult at the time of birth in first 12 hours or 24 hours, but maybe later on, we need to identify that subset where we think that yes, if we are giving steroid in this population by your intratracheal route, that it will be beneficial. Instead of saying that all the babies are being born and you are giving surfactant with steroids, and then in some it is going to cause beneficial, in some it is going to cause harm. So what we want is the maximum beneficial effect. And probably one way will be that if someone can look at the inflammatory markers, the cytokines, that we know that in some of the babies, they are out of by ventilation for 72 hours, 96 hours, but some linger on till at the end of first week. And then there will be some subcategories. So I feel that probably the new research questions should be in that direction, rather than saying blindly that you start giving surfactant steroids intratracheal to all and you will be able to decrease it. It may happen that you may show. But then what is happening to that subset who has unnecessarily received that? It is not that in all units less than 28 weeks or all are developing BPD. It's only 30, 40, 50% depending on.
So basically, we can broadly say that it's something like just we discussed a while ago, that why vitamin A only for ELBWs and not for the LBW. So basically, you have to understand the high risk population, the target population, whatever intervention you are offering to that population, and you actually have to weigh the benefit versus the harm. And then especially when it comes to hazardous or maybe dangerous therapy like postnatal steroids, be it in inhaled form or maybe systemic or be it oral or IV. I guess we are kind of coming to an end. Prashant, if I'm not wrong, it's 4:35. We know that BPD is a vast topic and there could be lot many other questions also on this, but maybe we could cover as much as possible. A big thanks to both the experts and the presenter, Dr. Suhani, for a detailed and elaborate discussion on this topic.
Yeah,
Over to you,
so-
Prashant.
yeah, thank you, Dhiren. And it was really a wonderful session. So before we end the session, there is a small poll questions for everybody. And I'm just launching it. All can answer. Just give me a minute. It's regarding our BPD only, and today's discussion was really informative. And we hope that students and everybody attended have learned something. So this is the poll. I hope it is visible. There are 6 questions and everybody is supposed to just answer. It will take just 5 minutes. And that was from the today's presentation only. We are thankful to Dr. Ashish Mehta, sir. He was, yeah, sir. Please, sir.
So basically, Prashant is making sure that all those who attended really were into it.
Yeah, I just made it while attending the session.
That's really great.
Yeah. Unfortunately, 5th question is somehow missing. So no need to answer that, but you can just submit the others. Yeah. So good. 2 questions, 2 participants have answered. Everybody can answer.
Let the audience answer so that.
Yeah, that is what I'm saying. Everybody. Yeah. By the time audience is answering, we are having Dr. Yogesh Parikh also with us. He is the project in charge of Neonatal Pathshala. Yeah, welcome Yogesh.
Yogesh bhai is muted, I think.
No, he can unmute himself.
Prashant is not Prashant. It is not allowed to unmute. Thank you, Prashant, and happy to see you, Niraj bhai, after since a long time.
Good afternoon, sir. Good afternoon. Good to see you, sir.
Yes, Pradeep bhai.
Maybe the online platform has given opportunities to many of us to, can interact with like-minded people. Like I don't remember when I last saw Dr. Niraj personally, but recently we have been on an online platform on a couple of times. Maybe last we met at the Neocon where we were a part of a panel discussion, isn't it?
No, we have invited Niraj bhai for the e-Gurukul in the neonatal case, maybe Dr. Somsekhar College. No?
But unfortunately, at that time, because of some personal thing, I had to cancel.
Yeah.
Yeah, so I'm just ending the poll and launching the result. Suhani, you can just answer all. If oxygen requirement is less than 30%, then it is called as?
Mild BPD.
Okay. In AIM study, incidence of BPD in infants less than 32 weeks was 33%. In BPD on chest X-ray, actually, both the answers are right. Normal and low lung volume can be there. Which one is the best to decrease the chances of BPD? If we talk only once. Yeah, so Lisa. And the last is, which ventilation therapy is best? Because we discussed a lot about that. So that is a volume target. Yeah. So thank you so much, everyone, for being an attentive audience. I just want to make an announcement that West Zone Neocon will be hosted by Gujarat NNF. That is on 26, 27, and 28 August at Udaipur. So all are requested to register for that. And at present, from NNF Gujarat, we present a token of appreciation to Suhani for presenting a wonderful seminar on bronchopulmonary dysplasia. and to both our experts, Dr. Pradeep GCM and Dr. Niraj Gupta, for answering all the questions, and to our moderator and chairperson, Dr. Dhiren Thakkar. Thank you so much.
Thank you very much.
Everybody can join the Neonatal Pathshala every Wednesday 3:30 p.m. by using the same YouTube and same Zoom link. So see you next.
Prashant, you can share this based on Neocon's brochure and link to register.
Yeah, I'll
as
just
early as
share.
possible.
Yeah, I'll just share in a day.
So every Wednesday at least.
Yeah, we'll get everyone will get an email also, probably, right?
Yes.
Prashant, everyone?
Yes.
Yeah.
Good.